pain, and we get a history from the EMTs that were on scene and brought him to the hospital. So he was at a party, he was dancing, and he suddenly felt chest pain. The chest pain was crushing across his chest. He had told the EMTs that it was the worst pain he ever felt in his life. He also had neck pain at that time. The pain was constant, but it improved mildly when he got pain medications from his friend. And we later found out that medication was Percocet. So he comes to the ER, and you see that he is inebriated. So he looks drunk, but he looks anxious, and he looks like he's in distress. It's hard to get a history from him because he is drunk, but his girlfriend's there and is able to help us out. So when we're asking the girlfriend for additional history, Dr. Stewart, what do you want to focus on?
I would want to focus on that, like, it was constant, so, like, I'm not sure, like, what,
okay.
like, sudden, like, if he, like, fell at the party or anything, or if he was, like, if he was doing drugs currently at the party.
Yeah, so let's take all right, so let's go with that the drugs part. So the girlfriend's not sure, but she's the patient was with old law school friends, and so they were having a good time. He apparently was drinking more than what he usually does, and he started to get a little drunk. He also was seen going to the bathroom with his friend, and as the night progressed, he started to get more and more wild. So to the point where he's jumping on tables and dancing. So what is there anything in that makes you more concerned? Or does it mean anything to
you? That he was drinking a lot.
Okay, so
which and alcohol is a depressant.
Okay, so if it's a depressant, would he be getting more wild, or would he be more down?
He would be more down due to his alcohol intake,
okay.
But drugs and his other medications could interfere with the alcohol.
Yeah, so you mentioned drugs, so you'd want to get a drug history on him?
Yeah.
Okay, so he lives by himself, but the girlfriend reports he drinks about 2 to 3 drinks a night after work to help him sleep, and he prefers whiskey. Is that a normal drinking pattern?
I would say that's kind of heavy.
Yeah, it's pretty heavy, especially if it's happening every night. That's probably heavy drinking. She says that she's seen him use cocaine in the past, and he has a history of methamphetamine use. Is that significant at all?
Both of those, if I'm not mistaken, are stimulants. So they would like increase his heart rate and definitely like impact his heart negatively.
Yeah. So if he's having chest pain, we can be thinking about possible cardiac issues. And so if he's taking stimulants like cocaine or methamphetamine, that can definitely affect the heart. Good job. All right. So Dr. Zarar. So at the party, he was up on the table and dancing. He eventually fell down on the floor, hit his left chest, and started complaining of chest pain. What does that mean anything to you? What are you concerned about when you hear that type of history? Okay, let's go with Dr. De Los Santos.
Sorry, can you repeat that?
Yeah. So when he was at the party, he was up on the table dancing. He fell down, hit himself on that left side, and started to complain of chest pain after that. So with that history, what would you be concerned about?
I would be concerned about like any trauma to any of the organs where he
Good.
hit.
Yeah, good. So what type of trauma? What's something specific you'd be worried about?
You said left side, right?
Mhm.
I would be concerned maybe with the spleen and maybe the stomach or kidney.
Good. Would those cause chest pain?
No.
Yeah. I mean, maybe because it's around the same area, but it's a stretch. What else can give you chest pain if he hits his left chest as he falls down?
Any broken ribs?
Definitely broken ribs. What if he says that he's short of breath and can't breathe?
Maybe. I don't know.
Okay. So what else is in the chest? So you said ribs. What else is in that area?
The lungs.
The lungs, exactly. So if he has, what would that be called? What type of trauma can you have to the lungs that can cause chest pain like that?
A pneumothorax.
Yeah. So Dr. Mushtaq says a pneumothorax. So perfect. So he can have a pneumothorax. And if I told you that he had jugular venous distension or venous distension in the neck, and he had tachycardia, and his blood pressure was going low, what would you be concerned about?
Would it be a heart attack?
Keeping on the pneumothorax side of it. So is there anything? So do patients typically die from a pneumothorax?
No.
They can if their oxygen saturation drops down too low and it stays low for a long period of time. But what type of pneumothorax do patients usually die from if it's not treated?
I'm not sure on that.
What if I told you that his trachea started to deviate? Dr. Abbasi, help him out.
Wait, can you guys hear me?
Yep.
Okay, so it would be tension pneumothorax because the lung starts moving like the trachea and like most of the body parts to the other side. And the way you would have to fix it would be well, first you take like a scan, like a CT scan, and then or a chest scan, and then you would do needle decompression.
Okay, so I agree with you with everything you said, except for the I'm assuming you meant a chest X-ray.
Yeah.
I wouldn't get a chest X-ray because you don't have enough time a lot of the time. So if you what you would have to do is you notice the tracheal deviation, you notice the blood pressure going down, you notice like the neck veins are distended. You would listen to that side of the lungs, see if you can hear breath sounds. If you can't, you know it's probably a pneumothorax, and you also will percuss and see if you hear it hollow. And if you're tapping on the back and it sounds hollow, that means there's air trapped in there. And so you have to stick a needle in pretty emergently to relieve that pressure, because with the tension pneumothorax, you can get air into the space, but you can't let it out. So you're just pumping air into that space through a one-way valve. And so you need to create that other side of the valve to relieve that pressure to allow your lung to reinflate. So good job. Yeah, it would be a tension pneumothorax that you'd be most worried about. But he's not really complaining of chest pain, so you would probably want to put that lower on your differential for now. Good. Okay, so I say that he so the girlfriend tells you that while he was there, and he started to feel chest pain. He vomited 3 times, and he was feeling nauseous. The vomiting didn't really help his pain, and that when he fell down, she didn't see him hit his head. Dr. Dixie, go. Why is that important to know? Why is it important to that history that I gave you? Why is it important to know? Let's go with Dr. Parikh.
Can you repeat the question? Sorry.
Yeah, so the patient, so the girlfriend said that he vomited 3 times. The vomiting didn't really help his pain, and that as he fell down, she didn't notice him hitting his head.
I guess we could like rule out something that has to do with like gastrointestinal, just because would it be possible that like if it was gastrointestinal, he would like throwing up would like relieve it, and like but like because when he threw up he didn't have that relief, that means it wouldn't be related to that.
Yeah, potentially. I mean, you can have GI issues where you vomit and you still have abdominal pain and stuff like that. But yeah, that's a really good thought. What about the head, that he didn't hit his head? Why is that important to know?
Because if he had a like concussion, that could cause his nausea, which is one of the symptoms.
Yeah. So if he hit his head and he has a concussion, that can cause nausea, that can cause some vomiting. What is dangerous in hitting his head that we want to make sure he let's say he did hit his head. What's something potentially dangerous that we need to rule out?
He could have had like trauma to the brain, so something like a stroke or like a brain bleed or something like that.
Yeah, not so much a stroke, but a brain bleed for sure. So your brain is encapsulated in a hard, closed space, which is your skull. And so there's nowhere for that brain to go. So if there's bleeding into that area, that blood is going to cause pressure on the brain, which can cause compression of the brain. And if there's nowhere for that brain to move, it's going to go straight down and herniate down. You can die from that. So you want to make sure that they don't have a brain bleed if they hit their head. He didn't hit his head, but you always want to keep that in the back of your mind, because this is the history is coming from the girlfriend, and so we really don't know. But good. All right. So perfect. And I think that was it with that history goes. Okay. So Dr. Mina, the patient is on sildenafil and losartan. Why is it important to know that?
Wait, did you call me? Sorry, I'm like having a really hard time hearing. Wait, did you call me? Sorry, I'm like having a really hard time hearing.
Yeah, so you have, for whatever reason, like a lot of feedback on your phone call, so yeah, you might want to call back and see, and try to hang up and call back and see if you can, if the audio gets better. Sometimes that works.
Okay, is there any way I could get on the Meet thing? Because the link isn't working for me.
Email us. We'll figure it out.
Okay, thank you.
No problem. All right. So, Dr. Brinley, let's focus on the sildenafil. Why is it important to know that he's on sildenafil? All right, let's go with Dr. Joel. Why is it important that he's on that we know he's on sildenafil?
Can you hear me?
Yeah.
Okay, it's important because it lets us know that it shows us he's taking medication for his past medical history of erectile dysfunction.
Okay, so why is that important to know?
It shows that there's not enough, blood being pumped to that area.
Okay.
So there might be some heart issue related to it.
Okay, good. So if we know that he has a lack of blood flow to his genitals, he's not able to maintain an erection, then that we can safely conclude that if he's having low blood flow to some areas of stenosis, he's probably having lower blood flow to the heart as well. And so that kind of gives us a warning sign of heart problems, also with strokes as well.
to know like if what the side effects could be?
Okay. So yes, it's important to know the side effects. Some of the side effects can include some headaches, but we don't think that the headaches are caused by this. What else is important to know?
Oh, it also, the way the medication works, it dilates the vessels.
Mm-hmm.
So I guess in the dilation of vessels, we'd have to like look at if the other medication that he takes also is involved in that.
Yes, but he's coming in with chest. So what? So let's say, what is the cause of chest pain that we're most worried about?
Sorry, what was that?
What is the cause of chest pain that we're most worried about? In
Like
general.
some type of heart related.
Yeah.
issue?
So But like, if anybody comes in with chest pain, what are you worried about the most?
If it's like a serious injury that could like cause death, or like
Yes.
is it
So
long term?
heart attack, right?
Yeah.
Yeah. So heart attack is like what we're most worried about. What do we typically give patients with a heart attack to help relieve some of that pain and the amount the heart has to work?
Nitroglycerin.
Good. So we give nitroglycerin. So what does nitroglycerin do?
It also dilates the vessels, so that
Exactly. Yeah.
Yeah.
So go on, finish that thought.
I was just gonna say it also dilates the vessels. Yeah. So if you're having like I guess it would affect your prescription of nitroglycerin if you already have like a medication that's dilating vessels.
Yeah.
Like for that.
So we have sildenafil, which
Yeah.
causes vasodilation, and we have nitroglycerin, which also causes vasodilation. And so if they both cause dilation of your vessels, and they're both working at the same time, your blood pressure is going to drop. And so
Yeah.
if you can't perfuse your heart attack that you're trying to help is actually going to get worse. So yeah, good job. All right, so let's see. Dr. Thornton, anything else that you want to know about the nitroglycerin?
Hello?
Yeah, Dr. Thornton?
Yes.
Right.
Can you repeat that one more time?
Yeah, so what else do you want to know about the nitroglycerin? We know kind of what it does and why we don't want to about the sildenafil. We know why we wouldn't want to give nitroglycerin with it. Anything else you want to know about sildenafil?
Maybe any complications that that's known to cause by taking it?
Yeah, I mean, it won't necessarily cause chest pain, and the patient would tell you that, he's doing great. It works very well for him. But what do you want to know about his usage?
Maybe if he's overusing it or taking too much than prescribed?
Potentially. There's one thing that you're missing, though. So if we're saying we can't give it with nitroglycerin, what is a something that we want to know about his usage?
I'm not sure.
It's okay. It's a little bit of like me asking you what I'm thinking. It's when he last took it, right? Because if he took it 3 days ago, then it doesn't really matter because it's not going to stay in the system that long. But if he took it today, like earlier that day, then we cannot give nitroglycerin because it can hurt the patient. Does that make sense?
Yes.
Perfect. All right. Good. All right. So let's jump to the physical exam. So, Dr. Neal, the vitals that I have for you is his blood pressure is 185 over 108. His heart rate is 121. His respiratory rate is 20. His temp is 98.4, and his O2 sat is 97 on room air. What sticks out to you in his vitals? Okay, that's okay. Dr. Safe, what sticks out to you?
I said his heart rate was really high and his blood pressure.
Okay, let's take his heart rate first. What are you worried about with his heart rate?
I was thinking that maybe it was because of if he took drugs or anything, his heart rate could be really high from the cocaine.
Okay, good. So how does that work? What does cocaine do, and why does that make your heart rate go high?
It's a stimulant, and that causes your heart to beat a lot faster.
Okay, good.
It constricts the muscles. Or not necessarily muscles, the vessels.
It constricts the vessels, but that wouldn't necessarily cause your heart rate to go high. But you're right. It increases your sympathetic drive. It increases the basically how hard your body's working, and part of that is going to be how fast your heart is going. Good. Now, what about the blood pressure?
For blood pressure,
You had mentioned it already.
yes, I have. I'm sorry, I forgot.
It's okay. Dr. Ali, you want to help him out?
Yeah, could you repeat the blood pressure again, please?
So it's 185/108.
So his both his diastolic and systolic both are high.
Okay. So
And
what does that tell us?
there's a lot of I'd probably say that's probably because his arteries are constricted
Yeah,
with
perfect.
cocaine and all that.
Yeah, so cocaine will cause vasoconstriction, and so when your arteries constrict, it increases the resistance on that artery. So your biggest modulation of blood pressure is how constricted your arterioles are, and so as they constrict more, your blood pressure is going to shoot up, and so your heart's going to have to work harder against that blood pressure to really push blood forward. And so, yeah, you're exactly right. The constriction of the arterioles is going to be what causes his blood pressure to go up. So good. So this can all be from the cocaine. Other than cocaine, Dr. Navneet, is there anything else you're concerned about? Any other cardiac issue or any other cause of chest pain that is consistent with these vitals?
Well, he was drinking alcohol, so maybe that could be an effect with both using cocaine too.
Potentially. The alcohol is a good point because alcohol withdrawal can cause you to be tachycardic and have an elevated blood pressure. So that's a very good point. But if he was drinking recently, he's probably not withdrawing. What if I told you that he's short of breath and his oxygen saturation is low and he's tachycardic? What would you be thinking of?
I'm not sure.
What if I say that his
Maybe an MI, a heart attack?
maybe an MI, but that'd be maybe. What if I told you that his left leg was swollen?
Oh, pulmonary embolism.
Pulmonary embolism, exactly. So tachycardia, shortness of breath, tachypnea, and low O2 sat. You have to be thinking of a pulmonary embolism. Good job. All right. So his O2 sat is normal. It's 97 on room air, and his respiratory rate is 20. So it's not that high, but it's kind of on the upper limit of normal. Good. So, Dr. Chloe, what do you want to know about in his physical exam?
I would like to know, to take his pulse, like in his hand or to a lower extremity, to make sure that it's consistent to rule out an aortic dissection. So he didn't have pain to the lower back, or at least he didn't say, but just want to make sure that that's not one of the issues.
Yeah, and why is that important?
Because it's deviating. The vessel is deviating and bringing blood to a different path. So I guess oxygen wouldn't be delivered to the body the way it's supposed to.
Potentially, yeah. So But with an aortic dissection, how do people die with aortic dissection?
I'm not entirely sure. I apologize.
It's okay. If your blood pressure is really low, and you have a big enough dissection, maybe that can cause hypotension, but that wouldn't really kill you. What will kill you is if you rupture that vessel and you start bleeding in the cavity, right? So that's a good, it's a good point that you brought up aortic dissection, because you want to make sure it's not aortic dissection, because that is it is associated with cocaine, and it's something that can potentially kill you pretty quickly. And doing an aortic repair is actually very difficult to do, and it's very invasive. So yes, you are right.
I would also, because sorry. Oh, you said something about him, like, I don't know if it was like slurring his speech or not acting himself. So I'd want to check to make sure, like, it wasn't, I guess the fall wouldn't cause a stroke, but the slurring of speech would be a sign of that. So whether that's due to the alcohol or a stroke, by doing like some type of neurological exam, like picking up your legs or something like that, to make sure both sides of the body work.
Yeah. So if you're, so what I would generally do is I would do a general exam first. I'd go and walk into the patient, see how they're doing. If they're talking to you full sentences, they look fine, they're not complaining of any pain, that patient's not really sick per se. They're not gonna crump in the next like hour or so. Versus if you go in and you see somebody that looks sick, they're breathing faster, they look like they're in pain, they're in distress, you need to really focus on that patient and make sure that they're stable. So for this patient in the general exam, he's well developed, well nourished. He looks like he's in distress, and he is diaphoretic, so he's sweating like crazy. And he has some slurring of speech. So you're right. If he has slurring of speech, you want to go back and do a neurologic exam, because the neurologic exam is going to help you distinguish if he has a stroke or is this just the alcohol. And so, like you were saying, if for him with his neuro exam, it's hard to do because he was drunk and he wasn't really following directions. And so, if he's moving all of his extremities symmetrically and it doesn't look like one is weaker than the other, you can be safe to think that he probably doesn't have a stroke because his history isn't really consistent with it. But if you tell him to, you see him raise his hand like this and he's not moving the other one, and you lift it up, and as soon as you let go, it just drops down, that's more consistent with a stroke. You want to make sure you do a full exam. And then because he had a fall, you're going to also want to make sure that there's no bleed. So yeah, good job. Dr. Garg, anything else you want to know about the physical exam?
Probably whether he's like responding all right, and if there's any tenderness anywhere. And like, also, I don't know if this is considered as like a physical exam situation, but I would look at his troponin levels, just because all of his symptoms are kind of lining up with symptoms of an MI. So typically when these patients come in, we're gonna if they have a heart attack, by the time they hit the ED, they've already drawn the blood and they sent it out to troponin to get the troponin, but it's going to take some time. So at this point, we don't have the results yet. But that's definitely a good thought. We're talking about the heart, so what examination would you want to do? Like his heart rate, and
just a regular heart exam, right?
So
for his cardiovascular exam, he's tachycardic, but there's no murmurs, there's no rubs or gallops. His pulses are intact, so the pulses in the hands or in the arms, the radial pulses, and the dorsalis pedis ones in his feet. Going back to the aortic dissection, if one was off, it would raise your suspicion for a dissection. And then his capillary refill is less than 2 seconds, which just tells us that he has good perfusion. Good. Any other examinations you want to do?
an EKG or an ECG.
Yeah, so before that though, when we're doing the physical exam itself, so we listen to the lung and to the heart. What else do you want to listen to?
The lungs.
The lungs, yeah, good. So his lungs are cleared to auscultation bilaterally, so they sound good on both sides. Now, we were talking about something earlier that we can potentially rule out with this, with this examination. Do you remember what that was?
A pneumothorax?
A pneumothorax, exactly. So what would you see with a pneumothorax?
Like a hollow sound?
Exactly. So you tap on the back, it sounds hollow. That means that there's air between the lung and the chest wall. And then if you don't hear lung sounds on that side, it's potentially a pneumothorax. Good job. Okay, good. So we went through the important stuff on the physical exam. Dr. Paduska, Julia, what labs are you most worried about? What would you want to get right away?
Definitely a troponin because that would be, if the levels were elevated, that would be indicating an angina or MI.
Yeah, good job. So troponin, like we said before, is going to be one of the first things that we're going to get. Anything else you want to get? As far as labs go, and we'll talk about the other tests after.
Maybe a BNP to see if it's like congestive heart failure or not.
Good. With CHF, you're probably going to have some leg swelling or some venous distension in the neck, and which he doesn't have. But this patient's BNP was normal. Anything else you want to get?
Well, if you said there was leg swelling, so you could do a D dimer to see if it's a pulmonary embolism.
Yeah. So this patient doesn't have leg swelling, but that's a good thought. If you're thinking about a pulmonary embolism, you can consider the D dimer. It all depends on what your pretest probability is. So, yeah. Anything else you'd want to potentially get? Dr. Alina, anything else you'd want to get?
So I would actually want to get a drug test just because he has a history of taking cocaine and he was drinking alcohol as well. So maybe just to check his liver is okay, and maybe get a test for his kidney functions to see if the electrolytes, are there any injuries to the kidney because of the electrolytes that are present in the kidney?
Yeah, so the electrolytes were normal. His kidney function was normal. The urine tox showed, so his tox screen showed that he had alcohol on him, which we kind of knew about from the history, but he was also positive for cocaine. So those are the two substances he was positive for, and so now we know he had cocaine on board, which is super helpful. The troponin was 1.2 when we drew it. So with the troponin, so first of all, Dr. Stephanie Pardara, with that level of troponin, is that normal? Is that high? Is that low? Or Parada, sorry. Dr. Parada. All right, let's go with Dr. Barraza.
That would be high, right?
Yeah.
No one's answering, so I'll answer.
It's okay. So yeah, that would be high. So with that, so what would you want to do next, Dr. Kaur?
Well, if the troponin's high, that means there's tissue damage in the heart.
Okay.
So I would say probably a chest X-ray.
You can get a chest X-ray. The chest X-ray, I gave you that's the chest X-ray I gave you. What does the chest X-ray look like?
It looks okay, kind of. Well, in the lungs look fine. In the heart, it looks a little abnormal, but not really. Can't really tell.
It was pretty normal. the X-ray was pretty normal. What else can you get?
EKG.
EKG, exactly. So EKG-A is what you get. And so what does that show?
In the first one?
Yeah, EKGA.
Well, with my group, we talked about it and we said an ST segment depression.
Good. Where do you see those depressions?
When it's kind of like going lower, I guess. I don't know.
Yeah, so the leads that we see the depression on are one, I think that's lead 2. Lead 3, it doesn't really quite look like it. Maybe a little bit in AVF. And then I saw V5 and V4. I saw some depressions too, and maybe V3. So yeah. So what does ST segment depression tell us? Let's actually go with Dr. Belinda. What does ST depressions tell us? Let's go with Dr. Motanya.
Would it mean that like your heart is pumping harder, so there's like more electrical signal or something?
Not necessarily. Let's see. Dr. What does that tell us? Dr. Wynn, Brian Wynn.
Oh, sorry. I thought it would be like a blockage of some sort.
Okay. So potentially, yeah. So we have ST depression. So what is that in general?
That would be something is wrong with like the pumping of the heart.
Okay. What's the name of that?
I'm not sure.
Okay. So it would be an NSTEMI, so a non-ST segment elevation MI, right? So he has a positive troponin, he has ST depressions, and so if you're having depressions and the positive cardiac markers, that tells us that it's an NSTEMI. The difference between an NSTEMI and a STEMI is that with an NSTEMI, you don't have full thickness ischemia of the heart, and so the way that the blood supply to the heart is the blood supply comes from the outside of the heart and penetrates inwards into that muscle. And so the outside of the heart gets most of the blood supply, the inside gets less. And so if there's any occlusion of the vessel, like you would get in an NSTEMI, and the flow is decreased, the inside is going to feel the effects more, and then the outside portion of the heart is going to feel it after that. And so you start to have ischemia on the inside, and it's all because you have that decreased flow. Now with the NSTEMI, you don't have complete occlusion of the vessel. With a STEMI, with a full-on heart attack, that vessel is entirely occluded, and you have complete cutoff of all blood supply to that area of the heart. So the full thickness of that heart is going to die. And so in this case, he has depressions, and he has an elevated troponin, so most likely this is an NSTEMI, and that's what he was diagnosed with. And so the patient was diagnosed with an NSTEMI and was started on appropriate treatment. So Dr. Manassi, what treatment would you give this patient if we're saying this is an NSTEMI? I can hear you, yeah. I can't really hear you anymore.
Is it better now?
Yeah.
Okay. Would you give anticoagulants?
Yeah. So So you would want to thin the blood. You want to make sure that you're not you decrease the risk of clotting. And why is that?
Because when it's going through the blood flow, you don't want it to make a bigger clot. You want the clot to break down.
Yeah, and so if you have an occlusion of some sort, it doesn't have to necessarily be a clot, but it can be. And you have blood flow going, even though it's not enough, you at least are reserving some of the heart function in that territory. And so if the way that end STEMIs progress to full-on STEMIs is if there's a clot that now is completely occluding that vessel from whatever lesion there was before. And so the way to prevent that is to try to prevent any clot from forming. And so we do use blood thinners, like in this case, we used heparin. And typically, heparin is a blood thinner that's usually given through the IV in this case, where I usually put it on a drip so that you can easily turn it on and off. Because the half-life of heparin is about 2 hours in case anything happens, and we don't want him to be his blood to be as thin, so we lower the risk of bleeding. So all of this is just to say that if you have an end STEMI, you want to prevent the clot formation by giving some type of anticoagulant, and that's going to be, for the most part, heparin. So on top of that, we know that he has cocaine on board. So the thought is that he probably had an MI because of cocaine. And so cocaine, like we talked about before, is going to increase your sympathetic drive. It's going to increase the amount that your heart and your body has to work. And so we want to decrease that as much as possible. So does anybody know what we would give to decrease the sympathetic response, or decrease the amount that he is his body's working or his heart is working? And it's okay if you don't. Anybody can answer. Dr. Ali is saying a beta blocker. And with cocaine use, that can actually cause his symptoms to be worse, because beta blockers block the beta portion of that signaling pathway, and you end up with unopposed alpha signaling. And so when you have only that alpha portion working, that actually causes really strong vasoconstriction, and all those vessels clamp down. So if you block the beta and you keep the alpha, all of his vessels are going to clamp down, and you can cause a significant increase in blood pressure. He can have a stroke. He can have a bunch of stuff. So beta blockers is the one thing that we typically won't give patients with acute cocaine use that are having like an MI. But I'm glad you brought that up, because it let me talk about it. So with cocaine use, to bring down the amount that the body's going to have to work, we would typically give a benzo. So in this case, they gave Ativan, and it's a benzodiazepine. It's basically like Xanax, and so that helped relieve some of his symptoms. And we didn't give nitroglycerin because he used sildenafil that day. So we admit the patient to telemetry, and we go back to the call room. We try to get some sleep, but at 6 in the morning, we're paged again, saying that he's complaining of more chest pain. And when you go and see him, he's breathing super fast and he's clutching his chest. So, Dr. Krisha, what do you want to do next?
Hi, can you hear me?
Yep.
Can you repeat your question, please?
Yeah. So at 6 o'clock, we get paged that he is complaining more chest pain. You go and you see him. He's breathing super fast. He looks uncomfortable. He's clenching his chest. He tells you, "I feel like I'm going to die." What do you want to do next?
You may want to look at his vitals at that time.
We do. And I did not write down his vitals. So we're going to assume they're okay. What else do you want to do?
I don't know, see if the symptoms worsen. I'm not really sure.
We can. So Dr. Mushtak is asking if he's still on the heparin drip. He is. Dr. Anushka is saying retest the troponin, and we can definitely do that. But what's faster? What will give us more information faster, Dr. Patel?
I'm reading the comments and I think EKG.
Yes, an EKG. Good use of resources. So yes, an EKG is going to be super fast, and we get the EKG seen EKGB. So Anushka, Dr. Anushka, what does the EKGB show?
Let me just pull it it looks significantly different compared to EKGA.
Okay, so what do you see?
I'm not really sure, but the depressions look bigger.
So do they still look like depressions?
I'm not too sure.
Okay, that's okay. Dr. Khomeini, what does it look like to you?
I'm trying to pull it up. I don't know what happened.
It's okay. All right, let's get somebody else to answer. So, Dr. Pratisha, what does that look like to you?
A STEMI.
The STEMI, good. And where are you seeing the STEMI?
Well, the depressions are all elevated now.
Okay, so what leads do you see it on? So on the EKG, the little numbers next to where or the numbers or letters next to it, those are the leads. So we see it on, this one actually is cut off because I think 1 is above, but we see it on 2, 3, AVF, AVL. Yeah, so 2, 3, and AVF, though, are the big ones. And that usually tells us that there is an occlusion of the right coronary artery. Because the EKG is basically giving us a snapshot at each of the different portions of the heart. So, but yeah, good job. It is an ST segment elevation. If we were to get a repeat troponin, what would you expect it to be? The same, lower, higher?
A lot higher now because there's more damage.
Exactly. So the troponin initially was 1.2 and then it went to 1.1. And that's when we started the heparin drip and all that. It looked like he was stable, getting better. We repeated the troponin, it was 1.8, and then after we repeated it again, it was 5.8. So he had an evolving heart attack. And so, what do you think the next best step is?
I think we need more intervention, kind of deeper. So cath lab.
Cath lab, perfect. We do a cath lab, and we notice that he has occlusion of the right coronary artery, and it's successfully stented, and the patient recovers. So good job. So this was a STEMI. So this patient initially had chest pain, was an NSTEMI, was put on appropriate treatment, but still developed a STEMI. So any thought of why that happened? And anybody can answer.
Can you repeat the question?
So the patient initially had an NSTEMI. So he had chest pain. We did the physical and all that. He had an NSTEMI. He then ended up having a STEMI later on, even though he was on heparin. So why did that happen?
Maybe his drug use made the medication less effective.
Potentially, I don't know if there's actual interactions between cocaine and or alcohol and heparin. I'd have to look that up.
Is it because, like, by the time he was brought to the hospital, like, too much damage had been done, or like the heparin drip wasn't enough? Maybe he needed a higher dosage of it.
Maybe, but we saw his troponin went from 1.2 to 1.1. If it was worsening damage, it would typically go up, right?
Yeah.
So it's probably not that.
Could there be some sort of other occlusion?
Maybe, but again, we would see he. So if there was another occlusion, that would typically get better with the heparin drip. Not all the time, but it usually would. Someone on YouTube is saying, could it be the amount of cocaine he did? And that is actually what we think happened in this patient. So he was doing cocaine, and so the cocaine has three ways that it can cause heart issues like a heart attack. So one is that it increases the demand of the heart because you're working super hard because the cocaine is stimulating the heart, and you're not able to give enough supply to that demand, and so you have that mismatch, and you cause something like an end STEMI, which is what he kind of presented with. The second is if he had a clot that formed there because the cocaine will cause you to be a little bit more thrombogenic. It affects the way that platelets adhere, and it can increase the risk of having a clot. So that's the second mechanism. The third is vasospasm. So if we did this coronary catheterization and we see his coronary arteries were completely clean, the vessels inside of his heart were phenomenal, great, they looked amazing. The fact that he did cocaine tells us that what most likely happened was he had vasospasm. So the cocaine causes the artery to actually spasm. And so if this is like the cross-section of the heart, if instead of having occlusion where it just narrowed, the vasospasm is going to cause complete occlusion. And that's more like what a STEMI is like. You have completely occlusion, you have completely occluded that vessel because the cocaine caused it to clamp down. And so it mimics a STEMI. For him, we saw that stenosis there, and it was most likely a clot. And so that wasn't what was going on with him. But if somebody does cocaine and their coronary arteries are pristine, it's probably vasospasm. There's another condition called Prinzmetal Angina that is caused by vasospasm of the coronary arteries and can cause symptoms like a heart attack, but it's usually pretty transient and it doesn't cause permanent heart damage, but you still want to treat it to make sure it doesn't. So there's a few questions here. So Dr. Patel is asking, what is the cath lab? The cath lab is just what we call the suite where we go and take people that are having a heart attack to do an angiogram where we inject dye into the arteries and see how they fill to see if there's any stenosis or occlusion. And the cath lab itself is just the place where we go and do that. In the cath lab, we typically will put a stent if we see a significant occlusion. Does his surgery in 2012 have any significance to the case? No, it doesn't. It just was part of his history. And surgical history, I always have a hard time of including. So if they usually have a surgery, I usually put it in. But it doesn't. For abdominal pain, which is what we're going to do next time, it is important because there's a lot of, if you have abdominal surgeries, it increases your risk of complications even after the surgery. So that is important to know. Now, let's say the patient recovers well and all that. He's still at risk for sudden cardiac death. Does anybody know why?
VFib?
Mm-hmm. VFib. And what is VFib? So VFib is an arrhythmia. It's caused by erratic contraction of the ventricle where you're not really synchronously contracting the ventricle, so you're not really getting good blood flow pushed out of that left ventricle. And so VFib is very dangerous because you can die from it because you're not having any cardiac output. And so a lot of times, or not a lot of times, sometimes when patients die from sudden cardiac death after a heart attack, it's because of VFib, because the change in the way in the heart muscle itself. So the death of the heart muscle itself also includes some of the signaling tracts of where the electricity of the heart usually flows. And so that change makes you more prone to having ventricular fibrillation or other arrhythmias. Alina's saying that maybe he didn't change his lifestyle and that can be too much for the heart. Definitely, if you're still using cocaine after a heart attack, you're probably stressing your heart out way too much. So, yeah. Somebody in the comments asking, is there a purpose of knowing the past surgery for this patient? No, not for this case specifically. For the future, it might be. If I said that he had a triple bypass in the past, yeah, that's going to be important. So surgeries are important, but you have to make sure it's in the context of what we're talking about. All right. So that is that's all that I have for you guys. Is there any last burning questions before we move on to the next group?
I had a question about so when he first came in, he said he had substernal chest pain.
Yep.
I was wondering why you never mentioned costochondritis.
So costochondritis is typically parasternal. So it's on the sides of the sternum. Substernal typically means that the patient is saying it feels like it's underneath my sternum, underneath my chest. And typically with substernal chest pain, it feels like a pressure or really like something's sitting on your chest. Versus costochondritis, it's usually on the side of the sternum. And then for the physical exam, if we push on the sides of the sternum and that reproduces pain, that's probably costochondritis.
Okay, thank you.
Mm-hmm.
I had a question about the beta blocker thing for cocaine. So, like, don't a lot of addicts, like, not talk about their history? Like, they probably lie about it. So how do you, like, know if they actually did cocaine or not, if they, like, choose to lie about it?
So most of the time, so that's a good question. Most of the time with cocaine use causing an MI, you're going to have a young patient with no coronary artery disease. And that you'd be a little bit more suspicious of cocaine use or other causes causing the heart attack. For elder patients, or I mean, he's on the younger side, but people over 50, you wouldn't really suspect cocaine use because it's not super common. So you ask them if you suspect it, and if they say no, then you can take them for their word. But if their blood pressure is super high and their pulse is high, you can always think about it. But it's not super common. So that's kind of the part where you have to weigh whether or not you want to ask about it or if you want to test for it. You can get a tox screen like somebody mentioned on YouTube, but if the suspicion is super low, then it's not a big deal. As far as the beta blocker part goes, there are some beta blockers that have both alpha and beta adrenergic effect. And so you can use those, although it's not super recommended in an acute MI. But if all this, you complete the workup and you do the stenting and all that stuff, you can do a beta blocker afterwards because the cocaine is probably left the system already. You just have to warn them that, hey, if you use cocaine and you're using a beta blocker, you can cause really bad elevated blood pressure and you can stroke out. So it's always risks and benefits that you have to talk to the patient about. And when you're deciding on what tests to order, you have to decide, what's most likely and what's not. Any other questions?
Yeah, thank you.
No problem.
Hello?
Yeah.
Okay, so I just want to know, I know in the case it said that he was a lawyer, and so we know with that it's going to be a very high stress job environment. So how would that go about with our diagnosis and us reviewing his case?
Yeah, so if he has a high stress job, he's going to be when you have high stress, your body is physically feeling stress as well, and so that can predispose you to having coronary events and other things like that. It's not. I'd have to look at the studies to see if there's an exact correlation, but you're at a little bit of a higher risk. I think what's more important in this case, though, I wouldn't say that the heart attack is because of his stress. I would probably say it's because of the cocaine. But let's say that he didn't do cocaine and he's just a lawyer. He's really stressed out. He doesn't do any of the other drugs or anything like that. The fact that he is stressed out and he's stressed out all the time, and his girlfriend says he's always under stress, I think that would be a good enough reason to suspect a heart attack. It wouldn't it maybe wouldn't be my number one diagnosis, but unless he has other signs and symptoms, but it would be enough to think about it. So you should think about it. But take it into context of everything else, if that makes sense.
Yes, thank you.
No problem. Any other questions?
I had a quick question.
What's up?
So we decided not to give nitro at the beginning because of the contradicting medication.
Yep.
If a patient comes in through EMS and they're unconscious and not able to tell you their medication history, and I believe nitro is something that's like commonly given for chest pain and stuff. What happens in that scenario?
So if you give it and he is on sildenafil, and they bottom out, you're just going to pump them with fluids and try to maintain that blood pressure. So you're right. That does happen sometimes. And so it's always a risk and benefit analysis. And I haven't personally seen a nitrosildenafil interaction. That just might be the area that I'm in, but it does happen. And so you just have to kind of treat what you see. And so if the blood pressure is low, you have to try to increase that blood pressure. If that makes sense.
Okay, thank you.
All right. So I am going to start the next one soon. So I appreciate all of your guys' time, and I hope you guys learned something. And if I didn't get to you this time, I'm going to try to get to you next time. So let me know if you have any questions. You can put them in the classroom stream.
Thank you.
Thank you.
No problem.
Thank you.
Thank you.
Thank you.